I have Dr. Osman Ahmed and Dr. Sid Padia. All right, so let's go to the next topic, embolization of any abnormal vessel versus only the painful side. Oz, you have any abnormal vessel. Sid, you have only the painful side. Oz, you want to start?
Sure. Yeah. I mean, I think there's obviously the Landers paper that suggests that the more you do, the better the patient does. I think, if you probably survey most of quote unquote experts in the MSK field, including Kuno himself, they will basically target any vessel that shows abnormal hyperemic blush. And I think probably, at least in my own practice, I have found more often than not, even if you go to the quote unquote other side, you'll see some anastomotic collateral network that then communicates to that side of the pain. I think especially in the era of temporary resorbable embolics, where sort of the embolic is more forgiving, it's probably better to sort of commit an error of commission as opposed to omission.
I don't necessarily, it's hard for me to disagree because I would argue that we don't really know yet. I'm on the fence with this one. I really am, because as Oz mentioned, the Landers paper, so Landers did this randomized trial, which was negative, and even in his own discussion said, we didn't embolize a lot of vessels. So and when we did in a subgroup analysis, then we did have better results. So maybe the argument is that you need to embolize more vessels. So how many do you embolize? Do you embolize 6, 8? Like, do you start going superior patellar and recurrent ascending tibial and all the other geniculars? So I don't know what the limit is. I do agree that just doing one may be inadequate in many. I just don't know where that midpoint is as to not too many. It's like the mama bear, right? Like, it's not too hot, not too cold kind of thing. I think we're going to figure this out eventually. This is going to be easier to figure out than the MRI question that you alluded to earlier. I just don't know what the right answer is. I do think embolizing more than one is probably favorable. So for example, if you have medial knee pain and you see the descending genicular artery lighting the medial side of the knee, yes, you should embolize it, but you should at the very least examine your other medial branches. Whether you examine your lateral ones, I tend not to. That being said, I do a cone beam CT, and if I see it wrapping around the patella, then I will. I don't know if we have a right answer here.
Okay, so let's phrase this question a little bit differently. Let's say you don't have access to resorbables. How about then?
So I don't have access to resorbables. I can talk about Paida, which we do have access to, but we're not using that for genicular artery embolization. So we are using permanent. I think many centers, if not most, in the United States are using permanent. We have had all of our results, including our published results, using permanent. There is a randomized trial, which has not yet been published, but was presented out of Brazil, where they showed pretty much equivalent results with permanent and resorbable, maybe hedging towards permanent in terms of efficacy, but not statistically significant. That being said, I think the safety profile for resorbables is superior. I have no doubt that it is safer. I was going to say you have to be more careful using permanent. I would argue you should be careful using both, right? The resorbable does give you a little bit more, I guess, room for error, is the best way to put it.
I certainly agree with that. I think if you are using permanents, which probably the majority in America are, definitely, and that's what I use sort of in the first half of my GAE sort of experience. Definitely less is more, whether it's the amount per vessel, the number of vessels you're doing. I think you still need to be very sort of much more confident that you are sort of selectively embolizing a vessel that you believe is a source of pain. I think the approach with a temporary, like an imipenem or a Lipiodol, is much different in the sense that, your threshold is reduced much lower, I think. I kind of go into vessels, say, it looks kind of abnormal. I'm going to just take this out because I know that the Lipiodol is going to wash away in like 10 minutes. And I don't really, there's really, arguably very little side effects related to it. So, but I'm with you, Sid. I mean, we don't know. There's a lot of unanswered questions. One of the unanswered clearly is how many do we embolize? I think the data is trending towards more is better. I think there is that one paper that just came out saying that even in severe OA, as long as you embolize 3 vessels, it seems like you're getting, decent results. I have another question for you, Sid, maybe that is on this line is, let's say you did do that DGA, right? And you clearly see anastomotic communications with the inferior medial, superior medial. and you see your particles or whatever you're injecting, sort of going into those vessels, would you go into those other vessels and still embolize them?
I might consider going into the other vessels and just doing a diagnostic angiogram. And if there is antegrade flow and hypervascularity and neovascularity, then I would. And if there isn't, I would not. So in most cases, when I do see that anastomotic communication, let's say I'm in the descending after the embolization, I see that anastomosis, and then I go ahead and catheterize, let's say, the superior medial. In almost every case, what you'll see is just communication back to your descending, but not to any area of hyperemia because that's been treated already. And so then I just look and I don't embolize.
Yeah, I agree. That's almost to a T what I do. I guess maybe where I have an issue is, what if you can't get in the vessel, or like it's a tiny vessel, it's hard to get into? Do you lower your threshold to abandon going into it?
Yeah, I might. I agree. I think I do lower it. That being said, this is cheating a little bit. Pretty much all of our patients are on trial, so we don't give up.
Yeah.
We don't want to. I know this is not fair, but on a clinical trial, you don't want to have technical failures, right?
Yeah.
So we make sure that we are technically successful in all our targets in terms of catheterizing and doing angiography.
Okay. I like it. All right. Let's switch gears a little bit and let's stick with the permanent particle topic. Let's go with size of particles. Oz, you have 200 to 250 to 300 micron. Sid, you have 100 micron. I know, Sid, you're doing more permanent embolic than temporary embolic, and Oz, I know you're the opposite, so we're putting you in a little bit of a bind here. But Oz, you want to start?
Sure. Yeah. I mean, I think speaking on safety, as we has been, I think, a little bit of the theme of this podcast so far. You look at the data that's out there. You have Bagla's sham data that showed that, using, or I don't think it was a sham study, it might have been another study, but it was Bagla's data that showed that smaller particles in that 75 micron range did lead to plantar paresthesia. And then you also have the Van Zadelhoff data that showed 2 patients who had, using, again, I think 75 or 100 micron, that had ankle paresthesias that didn't resolve at 4 months. And then also one patient with foot drop. So that makes me very nervous to use a small particle. Just in the spirit of safety, I'd rather have safety than lack of efficacy in some sense. But I think larger particle, if you're using permanent, probably makes more sense from a safety perspective.
Yeah, I mean, I agree. I think that there's probably a safe range, right? I wouldn't go more than 250 because then you're just going too big, and if you have a small microcatheter, it's going to be kind of messy. I wouldn't go lower than 100, right? So I think that's a reasonable range, anywhere from 1 to 250. And of course, it depends on your brand, right? Some of them are more compressible, depending on the manufacturer that you use. And I don't want to go into specifics of the pros and cons of that, but that would matter as well. So in other words, 100 for one brand is not necessarily the same as 100 from another manufacturer as well. But I think anywhere in that range, I think it is reasonable. Just don't go too small and don't go really large. It's kind of that sweet spot. I mean, going back to the Resorbable, I admit, even though I don't use it, I think it's eventually kind of going to be the future. The nice thing is there are, I don't know, maybe half a dozen companies that are studying resorbable embolics. And they, to my knowledge, they're trying to do it the right way. They're trying to do this through PMA level trials, many of them randomized trials. So they're trying to do really good work on getting this to market in a very fair, ethical way. And this might be the future to do resorbable embolics. Clearly, the initial study, which was done with imipenem, which is an antibiotic, but it's a crystalline imipenem, is resorbable in 1 to 2 hours, right? So, I mean, I don't know about you guys, but when I read that first paper, I was like, what? This makes no sense. But I mean, it works, right? So, something that's resorbing in 2 hours seems to at least permanently shut down the neovascularity, which is what is needed, right? So it's very appealing. It's just challenging in the US when you're trying to do a study, at least today in 2025, because we don't have these resorbable embolics currently available on the market. So when we're doing all our trials, we went with things that we are comfortable with, which are the permanent embolics. And then we kind of, if we can prove that it works in those, then we can start tweaking the formula.
Okay. So then here's the question, right? We have a lot of permanent embolics coming onto the market, as you said, right? There are multiple that are in trial right now. There are multiple that are available right now, off-label, but still available. Will permanent particles still be relevant in 5 years in this space?
I think there will always be a role for permanent, probably simply based on economics. Permanent spheres are cheap, and if they work, then we're going to come back to an economics argument to use them, depending on whatever setting you're in, And I think as Sid mentioned, we know it works. His data shows it works. Many people's data shows that it works. And there is some suggestion that maybe even works potentially better in the knee. So I think the question maybe probably more applies to other joints, MSK embolization as a whole. I don't see a role for permanent embolics there. If once we, and hopefully fingers crossed, start validating things like plantar fasciitis and shoulder and elbow and, wrist and all this stuff, then we're going to really probably see a renaissance or a resurgence of a resorbable or temporary agents, for that.
Don't inject permanent embolics for plantar fasciitis. That's probably a bad idea.
Good point. Very good point. Okay, so on that one, and Sid, the data you mentioned earlier about permanent versus resorbable, that was versus imipenem, correct?
Yes, it was imipenem, and I believe it was Embosphere, but I can't remember exactly.
Yes.
To my knowledge, I don't think it's published yet, but it was presented at CIRSE, and they showed better efficacy with permanent. Not statistically significant, but better.
All right, so real quick, if you're using permanent spheres, what is your angiographic endpoint? What is your dilution? What's your typical average volume injected?
So again, it depends on which spheres you use because they all come in, different vials. One comes in a 10, one comes in a 5, 7, et cetera. So this is what we do. We do Embozine 100 micron. It comes in a vial of 7 cc's total. We dilute it down to a total of 22 with using contrast and saline. So it's, we basically add 15, which is way more than what you're supposed to dilute it for because we're putting it through a 1.7 French microcatheter. It's a slow infusion, perhaps not as slow as prostate embolization, but the goal is not to go to stasis or even to substasis. The goal is to basically trim the hyperemia. So the average amount we're giving into a vessel is about 1 cc out of that 22 cc's. And the post-embolization angiogram, you want to have patency or antegrade flow of your main genicular artery and even of the second order branches. And then just trim that haze or that neovascularity, or however you want to term it. There is a little bit of, I would argue, a learning curve, and it's a little bit almost unsatisfying when you embolize it because you're giving so little, especially compared to, let's say, a fibroid embolization. But it really takes a very small amount to get the job done. The challenge is that if you over-embolize it, you can cause complications. And the most glaring ones I've seen or heard of are skin necrosis. In rare cases, we haven't had any, but I have heard of people having some really severe focal skin necrosis. So that's the main thing to worry about.
And I know you're using resorbables. So same question for imipenem and LaPaia joint. So imipenem, what's your endpoint dilution volume injected? Same with LaPaia joint.
Yeah, so for LaPaia joint, basically, I think we've talked about this probably in multiple conferences, but it's a 3-to-1 emulsion of Lapiodol with OptiRay contrast. And so it basically takes 6 cc's of Lapiodol and then put it with 2 cc's of OptiRay. And then basically it's, and again, I think this is why I have liked this technique, is it's much more objective and it's much more like kind of in line with what Sid is saying, like a UFE. You basically just inject it until it's completely static. And if anything, you inject it till it starts refluxing down other branches and then you're done. So when you do that, it ends up being roughly 0.5 cc's, with sort of a 95% confidence interval between like 0.3 and 1 cc. So yeah, so that's typically what I do. And it's probably, rarely do I ever give more than 3 total cc's in a case.
So the one thing I like about that, Oz, is, and I've never used it, and I'm not going to argue against you this time, it's reproducible, right? You can teach somebody else to do it. You could just say, go to stasis. That's it. And everybody knows what that means, right? This challenge of what I said is, keep the first and second order branches. Everyone interprets that a little bit differently, right? We all know
that's challenge.
And it's not quantitative, right? We don't have a great way to quantitate angiography in terms of flow. Right? Like you can't put a number on how good the flow is. People have tried. It's just kind of always fell through. So your idea of like using Lapiodol and saying, look, just go to stasis. That's it. You could tell that to 10 people and all 10 people will understand what you're talking about.
That's what I found to be the most appealing about it, honestly, compared to like what you said. Like, because I think pruning is like, A, it's incredibly subjective, and then B, it's hard to get it, right? Like you give like an extra 0.2 cc's, you're like, oh, all of a sudden you're static. You're like, oh crap, like, but and it's very counterintuitive. Like you said, it's so hard to convince your brain to say, less is more, as an interventionalist. But whereas Lepidol or these temporaries like imipenem, you can go to just stasis and just be like, all right, I'm done.
So how do you make sure imipenem, Os?
Well, I don't use imipenem. I know it's available and I've seen people use it. Basically comes in a powder form and you inject it. You take 10 cc's and you inject it into the vial and basically shake it vigorously. And then you essentially draw up aliquots of it, as needed. Talking to Dr. Kuno, one of the main things he sort of also always sort of emphasizes, you have to constantly shake it, especially right before you give it, because it will fall out of solution very fast.
Okay, good to know. Yeah, and it's interesting. I mean, I think a lot of people in the U.S. probably don't have access to it, just being a controlled antibiotic, right? Incidentally, I'm just putting it on formulary just to have it available for some of my patients as we get ready to start having resorbables, and hopefully the relatively near future. But that's super helpful.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.